Now we are going to discuss a topic which is esophagitis. Esophagitis is defined as an injury to esophageal mucosa which is followed by inflammation. It includes reflux esophagitis, very important, infective esophagitis, and there are other causes of esophagitis like intake of drug like tetracycline and radiation, Crohn's disease, and various vesicobullous skin diseases. So once again the definition, it is defined as injury to the esophageal mucosa which is followed by inflammation and includes reflux esophagitis, very important. I just tick it, and infective esophagitis. Reflux esophagitis. Reflux esophagitis is due to when there is reflux of gastric contents into the lower esophagus, as the esophageal epithelium is sensitive to acid contents of the stomach. The clinical condition associated with this is called gastroesophageal reflux. So once again, reflux of gastric contents into the lower esophagus, as the esophageal epithelium is very sensitive to acid contents of the stomach. The clinical condition which is associated with it is called gastroesophageal reflux disease. Now, etiology, physiological factors, decreased esophageal anti-reflux mechanism, presence of sliding hiatus hernia, slow clearance of reflux material, that is, if the reflux material or the gastric contents enters the esophagus, they are cleared slowly, delayed gastric emptying due to many diseases, that the gastric emptying is delayed, delayed healing due to repeated trauma. Once there is injury to the esophagus by repeated reflux contents of the stomach, the process of healing is delayed and leads to fibrosis. Damaging agents in the gastric juice, that is, the acidity of the gastric juice is increased gastric tension, that the gastric contents remains there for a longer period of time, hypersecretion of gastric acid, that is, there are diseases like Zillinger-Ellison syndrome and there is increased secretion of the gastric acid, persistent vomiting, nasogastric tube, or you can say that nasogastric intubation, surgical vagotomy, neuropathy in alcoholics and diabetics. So among that, there are many. The important one are, I am just going to tick mark them. This is, that is, delayed healing due to repeated trauma, increased gastric retention, damaging agents in the gastric juice, very important, hypersecretion, very important causes. So I've just tick marked them so that you should know at least these four of them, very important. Anatomical factors. Now, alteration of intra-abdominal length of the esophagus. That is, the length of the esophagus is shorter than the normal. Alteration in the length of the phrenoesophageal ligament. Repeat, alteration in the length of phrenoesophageal ligament, alteration in the angle of His, that is esophagogastric angle, very important. Now I show it to you. This is the angle, the esophagogastric angle, and this is here. Change the color again and again. Now this angle is between the greater curvature of the stomach and the esophagus. As you know that it's the greater curvature of the stomach. This is the greater curvature of the stomach and the esophagus. Normally it is an acute angle. It is an acute angle, that is less than 90, and acts as an anatomical sphincter, preventing the reflux of the stomach acid, digestive enzymes. Stomach acid, it prevents the reflux of stomach acid, digestive enzymes, and duodenal bile from entering the esophagus, But when it becomes obtuse, that is, this angle is more than 90, or the angle is disturbed, in simple words, as seen in hiatal hernia, the episodes of GERD, that is gastroesophageal reflux disease, are increased. Very simple. If this angle is disturbed, then it acts as a barrier from the contents of the stomach. This is stomach, and the contents can freely pass from the stomach upwards. Alteration in the mucosal folds, that is rosettes or mucosal rosettes, which are present at the gastroesophageal junction only when the normal angle of His is present. These folds squeeze together to form a weak anti-reflux valve. Again, obesity, they disturb all the process. That obesity causes decrease in the elasticity of the muscles, so it's a very important cause. Now, factors in which abrupt intra-abdominal pressure rises or increased: cough, straining on passing the stool, bending, pregnancy increases the intra-abdominal pressure, increased gastric volume. Other factors: smoking, alcohol, intake of tea and coffee, spicy food, overeating, lack of exercise, stress. Clinical features: heartburn, dyspepsia, particularly after heavy meals, epigastric pain, regurgitation of the food. Of course, if the food is there, then it is going to be regurgitated, and there can be aspiration of that food, dysphagia, and hematemesis. Why? There is going to be ulceration, there is going to be first there is going to be infection and ulceration, and then there is going to be hematemesis. Complications: reflux esophagitis, sliding hiatal hernia, shortening of the esophagus. Now the shortening is repeated infections leads to inflammation, and when inflammation, there is ulceration, there is healing of the ulceration, there's going to be fibrosis, and once there's going to be fibrosis, there's shortening of the esophagus, ulcer formation, as I told you, stricture formations, of course, there's going to be infection, inflammation, fibrosis. So stricture formation is there, very important cause, stricture formation. So complications are like this. I tick mark them, which are which you should remember that. And hematemesis and melena, Barrett's esophagus, we'll discuss in detail Barrett's esophagus, a topic very from your examination point of view, and carcinoma of the esophagus. Morphology, demarcation is lost at junctional mucosa. The affected mucosa is red, friable, and erythematous. In chronic cases, demarcation between squamous and columnar epithelium. Again, same old repetition of the past. That is, there is demarcation of the epithelium between squamous and columnar epithelium. There is nodularity. Now, the case is chronic, stricture formation, ulceration, erosions, they are present. I repeat that in the initial stages, demarcation is lost at junctional mucosa. The affected mucosa of the esophagus is red, friable, and erythematous. In chronic cases, demarcation between squamous and columnar epithelium, there is nodularity, there is stricture formation, there is ulceration, there are erosions, they are present. Moderate to severe cases show inflammatory cells in the epithelium. Basal zone hyperplasia, we're coming to that. And then elongation of lamina propria papillae up to 2/3 of the epithelium. Look at that. This is esophageal gastric junction. This is which is marked with green, and now I am marking it with red. Then what? Lower esophageal mucosa marked with green, and area of ulceration. This is the area of ulceration present here. I'm going to see it in green. Area of ulceration. Acute esophagitis. Esophagitis is really caused by other agents than the reflux. Acute esophagitis may be caused by infective or physical agents, but the most important cause is reflux of the gastric contents. Bacterial infections are rare in causing acute esophagitis. Skin diseases like pemphigus cause esophageal ulceration. Pemphigus cause esophageal ulceration with separation of the epithelium from submucosa, producing blisters leading to erosions. Fungal infections in immunosuppressed patients, very important. Discuss in detail. We are going to discuss it in detail. Viral infections, particularly herpes simplex and cytomegalovirus, are increasing in patients of AIDS. Acute esophagitis can also be produced by irradiation or ingestion of caustic agents. So, repeat once again, fungal infection in immunocompromised patients, viral infections like herpes simplex virus and cytomegalovirus is on the increase in patients of AIDS. Acute esophagitis can also be produced by irradiation or ingestion of caustic agents. Look at this. This is the epithelium. This is the stratified squamous epithelium. And look at the inflammatory cells. Acute esophagitis, increased neutrophils in the mucosa and submucosa, shown here, marked with arrow. Infective esophagitis, a number of opportunistic infection in immunocompromised individuals cause esophagitis, which include Candida, herpes simplex, cytomegalovirus, and tuberculosis. So, in immunocompromised patients, these infections, they can cause infective esophagitis like Candida, herpes simplex, cytomegalovirus, and tuberculosis. Candida esophagitis, usually due to Candida albicans or Candida tropicalis, most common cause of infectious esophagitis, associated use of antibiotics, malignancy, steroid therapy, corticosteroid therapy, diabetes mellitus, patients of AIDS, that is rheumatic disease, elderly patients, debilitated patients associated with cytomegalovirus or herpes simplex esophagitis in immunocompromised patients. So I repeat once again that usually Candida esophagitis is due to Candida albicans or Candida tropicalis, most common cause of infectious esophagitis associated with excessive use of antibiotics, seen in malignancies after taking corticosteroid therapy, diabetes mellitus, in the patients of AIDS, HIV infection, rheumatic disease, elderly patients, debilitated patients, and also associated with cytomegalovirus or herpes simplex virus esophagitis in immunocompromised patient. Patients with Candida esophagitis present with dysphagia or odynophagia. Odynophagia is painful swallowing. Then the other is endoscopic finding, grayish-white pseudomembrane or plaque-like appearance in middle or distal esophagus. I repeat that endoscopic findings are grayish-white pseudomembrane or plaque-like appearance in middle or distal esophagus. The mucosa is erythematous, oedematous, or ulcerated, and this is called cottage cheese esophagus. Look at that. This is the esophagus, and you can appreciate these areas. There are the fungal infections, that is the Candida, which are present, again marked with white arrow, white circle. Tan yellow plaques with mucosal erythema. The mucosa is red. Again, you can find fungal hyphae. These are the fungal hyphae. And these are the fungal spores, which are shown by GMS staining, that is Gomorrhe's methanamine silver staining, fungal spores and pseudohyphae in squamous epithelium, which are demonstrated on GMS staining. Herpes esophagitis. It is the second most common cause of infectious esophagitis after Candida. Of course, it's the viral infection. In healthy patients, it is self-limited. Can cause esophageal perforation or disseminate in immunocompromised patients. So it can spread in immunocompromised patient, but in healthy patients, it's a self-limiting disease. May be associated with secondary bacterial or fungal infections. Associated with herpes simplex virus 1 and 2 cause herpes esophagitis. In immunocompromised patients having esophageal ulcers, one must suspect herpes simplex virus. I repeat it, in immunocompromised patients, if there are esophageal ulcers, one must suspect or rule out herpes simplex virus infection. Gross appearance: shallow vesicles and ulcers may combine together into extensive area of erosion. Microscopic features: ulcers contain necrotic debris and the exudate contains neutrophils. Ulcers contain necrotic debris and exudate contain neutrophils. Viral inclusions are present in multinucleated squamous cells at ulcer margins. So the squamous cells which are multinucleated present at the ulcer margins, they contain viral inclusions. Inclusions are usually Cowdery type A, that is, they are dense eosinophilic, intranuclear and cytoplasmic inclusions, and thickened nuclear membrane with a clear halo. Also, ground glass inclusion that fill the nuclei and nuclear molding. These are the features. Ulcers contain necrotic debris, exudate contains neutrophils, viral inclusions present in the multinucleated squamous cells at ulcer base. Inclusions are usually Cowdery type A, which are dense eosinophilic intranuclear inclusions, thickened nuclear membrane with clear halo, and ground glass inclusion that fill the nuclei and there is nuclear molding. Aggregates of macrophages having convoluted nuclei are adjacent to inflamed epithelium. So adjacent to the inflamed epithelium, one can find aggregates of macrophages, and these macrophages have got convoluted nuclei. Look at that. This is herpes infection, and here the erosion is seen, that the stratified squamous epithelium is being eroded. Erosive herpes esophagitis. Now here what I told you, that there are squamous cells and they contain the inclusions. Cowdery type A inclusions. Herpes esophagitis with Cowdery A type inclusions and multinucleated cells with nuclear molding and ground glass nuclei. Again, these are ground glass nuclei. Barrett's esophagus: replacement of distal stratified squamous epithelium by columnar epithelium due to prolonged injury, that is intestinal type columnar metaplasia. When I say intestinal type columnar metaplasia, it means that it contains goblet cells. Cause is long-term gastroesophageal reflux disease. Male to female ratio is 3:1, usually present in the 4th to 6th decade of life. And very important point, precursor of esophageal adenocarcinoma. I repeat that there is Barrett's esophagus is the replacement of the distal stratified squamous epithelium of the esophagus by intestinal type of columnar epithelium, which is containing goblet cells. Cause is gastroesophageal reflux disease. Male to female ratio is 3:1, seen in 40 to 60 years of age, and it is a precursor lesion for esophageal adenocarcinoma. Morphology: the mucosa is red, velvety, which is present between smooth, pale, elongated squamous mucosa. Metaplastic intestinal type of columnar epithelium and glands are present. They are the microscopic features of Barrett's esophagus. Barrett's esophagus is subclassified into long segment when greater than 3 centimeter or short segment when less than 3 centimeters. Now look at that. This red velvety mucosa shows Barrett's esophagus, and this is normal, smooth, pale, squamous mucosa of the esophagus. Barrett's epithelium, I'm showing it in a flow chart, may undergo dysplastic changes or dysplasia, carcinoma in situ, invasive adenocarcinoma, and it has got, now say that it's more than about 10 to 15% increased risk of invasive adenocarcinoma, but in most of the literature it is mentioned that 5 to 8% increased risk of invasive adenocarcinoma. Now you can appreciate that very simple. This is the stratified squamous epithelium, and this is replaced by intestinal type of epithelium or glands, and these glands are lined by columnar epithelium. Sorry about my handwriting. And these are the clear cells present. These clear cells, they are the goblet cells. So intestinal type of columnar epithelium, that is containing goblet cells, very important. Barrett's esophagus showing intestinal type of columnar metaplasia. These are glands which are lined by columnar epithelium containing goblet cells. I am stressing on that. These goblet cells contain mucin. This is the mucin. I marked it with M, which is blue-gray tinge on H&E staining, and then of course there is a stratified squamous epithelium. I have already marked it. Now this is an Elchian blue staining in which the goblet cells, they are stained blue. Now again there is a photograph showing that stratified squamous epithelium of the esophagus, and then there is intestinal type of epithelium, and then there are glands which show stratification of the nuclei showing dysplasia. This is Barrett's esophagus with some dysplasia of the columnar epithelium. There is a long-term risk for Adenocarcinoma, the short-term problem is inflammation or ulceration. This is the esophagus, and this area shows, see, adenocarcinoma or gross appearance of carcinoma, marked with yellow circle and red circle. The normal tan brown upper esophagus mucosa is at the far left, that is, the distal is replaced by Barrett's mucosa, which is producing a darker, slightly erythematous gross appearance. In the distal esophagus has risen a large ulcerating adenocarcinoma which extends up to this is the stomach. So the adenocarcinoma, which is produced at the lower end of the esophagus, is extending into the stomach. Now, tumors of the esophagus, usually we divide benign and malignant. Benign tumors, small in size, less than 3 centimeter, uncommon. Intraluminal tumors, most common is leiomyoma. Somebody asks you commonest tumor of the stomach and the most common tumor of the esophagus, benign. The answer is leiomyoma. Very important viva question. Fibroma, lipoma, hemangioma, neurofibroma, and then mucosal tumors, which is squamous cell papilloma, fibrovascular polyp, inflammatory polyp, malignant tumors. Now, the most common malignant tumor is squamous cell carcinoma, which is about 85 to 90% of cases, and then adenocarcinoma, seen almost in 10% of cases. Esophageal carcinoma makes 6% of all GIT malignancies or cancers, whereas malignant stromal tumors are rare. They make up 6% of all GIT cancers. Malignant stromal tumors are rare. If somebody asks you how common is leiomyosarcoma of esophagus, the answer is very, very rare. Two main types, squamous cell carcinoma, forming 90% of the tumor of the esophagus. Commonest sites, upper and middle 1/3. Adenocarcinoma, lower 1/3, and mostly it is due to Barrett's esophagus, which is a precancerous lesion, forming 10% of the tumor. Site is lower 1/3 of the esophagus. Malignant tumors continue. Carcinoma of the esophagus is an aggressive tumor. It is diagnosed late, and it is diagnosed after the tumor has infiltrated the anatomical limits of the organ, because there is no serosa in the esophagus and it's rich in lymphatics. More common in men over 50 years of age. Esophageal carcinoma, as I told you, forms 6% of all GIT malignancies. Prognosis is not good. 70% of the patients die within 1 year of diagnosis because the tumor has already passed through the limits of the esophagus when it is diagnosed. 5-year survival rate is is seen in 5 to 10% of cases. Etiology, diet and personal habits, very important. Heavy smoking, heavy intake of alcohol, food contaminated with fungus, nutritional deficiency of vitamins and minerals like vitamin A deficiency, vitamin E deficiency, deficiency of vitamin C, minerals like calcium and scandium, hot beverages, nitrosamides compounds which are present in the junk food, smoked fish, and then esophageal disorders, as I have already told you, that achalasia, hiatus hernia, Zenker's diverticulum, corrosive strictures, Plummer-Vinson syndrome, and in adenocarcinoma, Barrett's esophagus. I repeat, esophageal disorders, very important from the viva point of view. Achalasia, hiatus hernia, Zenker's diverticulum or diverticuli, all the diverticula, they may end up, but the most common is Zenker's diverticulum. Corrosive strictures, Plummer-Vinson syndrome, and Barrett's esophagus in adenocarcinoma. Other disorders like celiac disease, epidermolysis bullosa, and tylosis, which is thickening of the skin of the palms and sole, that is hyperkeratosis of palm and sole. Geographical distribution, well, it is seen in the incidence is much higher in certain countries, common in China, Japan, Iran, Hong Kong. Very high incidence is noted in Western Kenya, where there is high consumption of traditionally treated milk called Mursik, and that contains acetaldehyde, which is a carcinogenic. Mutations, amplification of the transcription factor gene SOX2 or SOX2, loss of functional mutational in tumor suppressor genes like p53, CDH1, and Notch1. But you should remember these two things, very important, and that is, this is very important for you. Genetic mutations, even if you write p53 and CDH1, more than sufficient. In high-risk patients, human papilloma virus infection may contribute to the esophageal squamous cell carcinoma. Squamous cell carcinoma, well, seen between the age of 60 and 70 years, more common in men, middle third of the esophagus. Now this is very important MCQ, which is the most common site, very important viva question. It is in the middle one third of the esophagus. Please remember it. Morphology, it appears as a dysplastic lesion or in situ lesion termed as squamous dysplasia. Which is a small grayish white plaque in the mucosa. I repeat once again, it begins as an in situ lesion, which is termed as squamous dysplasia. This is squamous dysplasia. We call it as squamous dysplasia, and it appears as a small white plaque in the mucosa. Later on, it becomes invasive and forms a tumor mass. Initial small plaque in the mucosa ultimately forms a tumor mass. It can be polypoidal type, ulcerative type, fungating type, ulcerative type, fungating type, annular type. Annular type is infiltrating type. Distribution: upper third 30%, that is in the upper third of the esophagus, upper one third of the esophagus, it is 30%, middle one third 50%. That's why I called it is the most common site, that is middle one third. Middle one third is the most common site, which is 50%. The tumor is seen 50% of cases in the middle one third, lower one third 20%. But if somebody asks you which is the commonest cancer in the lower one third, of course adenocarcinoma, because it's due to Barrett's esophagus, and Barrett's esophagus is a precancerous lesion. Gross appearances: polypoidal mass in the lumen, as I told you, very simple. It can be ulcerative type lesion, and that ulcer has got necrotic base with everted edges. There is a necrotic ulcer and raised edges, everted edges. And then fungating type, and then diffuse infiltrating lesion, as I told you, that is annular type, which cause stenosis of the lumen. Polypoidal growth. Now you can well appreciate this polypoidal growth here. Look at the polypoidal growth, and it's projecting into the lumen of the esophagus. Here you can see an ulcerative lesion, that is reddish, irregular, ulcerated, exophytic, mid-esophageal mass present on the mucosal surface, is a squamous cell carcinoma. Squamous cell carcinoma, well, look at that, already circled. Here, this is a gross. Microscopic features are the same, well differentiated, maybe, or maybe moderately differentiated. Well differentiated, they are prickle cells, their keratin formation, their keratin pearls or epithelial pearls, moderately to well differentiated. Variants, please remember one or two variants, very important. Maybe verrucous type, basaloid type, spindle cell type. These are the common variants, that is verrucous, spindle, and basaloid type. Metastasis: esophagus has rich network of this is wrong written here, of lymphatics. It's a typical error. Lymphatics, which promotes metastasis. Sorry about the typical error. Direct spread, well, it can spread directly from the esophagus or direct extension to the trachea, bronchus, mediastinum, pleura, recurrent laryngeal nerve causing hoarseness of voice, aorta, and intraluminal satellite tumor nodules are present many centimeters away from the tumor mass. I repeat that the esophagus has rich network of lymphatics which promote metastasis, but the direct spread is there, and direct spread is towards trachea, bronchus, mediastinum, pleura, recurrent laryngeal nerve leading to hoarseness of voice, aorta, and intraluminal satellite tumor nodules are present many centimeters away from the tumor mass. Lymphatic spread depends upon the location of the tumor in the esophagus. Very simple. Whether the tumor is located in the upper one third or in the middle one third or in the lower one third. When it is located in the upper one third, spreads to the cervical lymph nodes. When located in the middle one third, the esophageal cancer spreads to the mediastinal, paratracheal, and tracheobronchial lymph nodes. When in the lower third, metastasis to lymph node involved are gastric and celiac. So gastric and celiac lymph nodes are involved when the tumor is located in the lower one third. Blood spread is through to the liver and bone and brain, liver, bone, brain. But the important thing is you should know that these three things very important. When the tumor is according to location, when the tumor is in the upper one third of the esophagus, cervical metastases are to the cervical lymph nodes in the middle third, then mediastinal, paratracheal, and tracheobronchial lymph nodes, and when in the lower one third, metastases to the gastric and celiac lymph nodes. Look at that, the histological features, the tumor pleomorphism and eosinophilic cytoplasm, pleomorphic nuclei, and you can also see hyperview infiltrating nest of neoplastic cells having abundant pink cytoplasm and distinct cell borders typical for squamous cell carcinoma. Esophageal carcinomas are usually not detected early and have a very poor prognosis, as I told you. And clinical features, progressive dysphagia. Well, the, the, in achalasia, both dysphagia to solids and liquids, sometimes more to liquids. But here, initially, there is no dysphagia or no difficulty in swallowing of the liquids, but to the solids. So, and that too is progressive. Progressive dysphagia, very important point in the clinical feature, right? Odynophagia or painful swallowing, regurgitation of the food. Food does not pass through the esophagus, so it's going to be regurgitated. Vomiting, weight loss, because absorption of the food is not there, so one is bound to lose weight. Ulceration and hemorrhage. Fistula formation, well, by direct extension, tracheoesophageal fistula formation takes place. Diagnosis, endoscopy and biopsy. They are the diagnostic tools. Treatment, resection, radiation and chemotherapy. 5-year survival rate is 5 to 10% depending upon the stage. Adenocarcinoma of the esophagus, age is 40 to 50 years, 7 times more common in men, very important. Distribution, middle and lower one third of the esophagus, but you must answer lower one third is the commonest site due to the presence of Barrett's esophagus or pre-existing Barrett's esophagus. And what is Barrett's esophagus? Barrett's esophagus is metaplasia of the normal squamous epithelium of the esophagus by the intestinal type of columnar epithelium containing goblet cells. This is Barrett's esophagus. These things are on your fingertips. definite association with Barrett's esophagus and obesity, which is related to GERD, that is gastroesophageal reflux disease, smoking, important cause, exposure to radiation, metastasis early via lymphatics, then squamous cell carcinoma, decrease intake of fresh fruits and vegetables, mutations, they're very important. P53 and CDNA2 are deleted at an early stage. If you don't remember this, at least remember that mutation of P53, and then there is overamplification, that overamplification of oncogenes, which are EGRF, cyclin 1 and cyclin E. Very simple to remember. Morphology first appears as a flat, elevated patch, intact mucosa of the distal one-third of the esophagus, and may invade gastric cardia. I repeat, it appears as flat, elevated patch in the intact mucosa of distal third of the esophagus and may invade gastric cardia. The mass which is formed is up to 5 centimeter or more, which either ulcerate or infiltrate diffusely or invade deeply. First, it appears as a flat, elevated patch in the intact mucosa at the distal third of the esophagus, invading the gastric cardia. Then, formation of mass, which is 5 centimeter in size or more, which ulcerates, it infiltrates diffusely, or it invades deeply. Gross appearance, again continuing of that continuation, exophytic or infiltrative. Microscopic features, intestinal type, adenosquamous type, adenoid cystic type, and mucin producing type with gland formation along with the presence of signet ring cells. Poorly differentiated in the form of sheets of small cells. Prognosis, before spread, 5 years survival rate is in 80% of cases, otherwise it is 25%. This is the microscopic appearance of adenocarcinoma of esophagus. You can well appreciate the glands, infiltrating the muscular coat, and they are lined by cells having hyperchromatic nuclei. Nest of neoplastic glands are infiltrating through the submucosa at the right, and they are present in the muscular coat.